I do want to talk to you about the end of life care for a lot of patients and how you deal with that process, right? So it's in the same ballpark, especially when you are talking about the empathy versus the compassion.
Mm-hmm.
But I think now that more states, I think we're up to 11 states now that has okayed assisted, what's it called? Doctor assisted suicide. Is that the term?
So I don't, that's kind of a charged term, I think, and I don't, and I'm not the expert on this, but I think it's like there are death with dignity acts where, yes, if you want to boil it down, it is physician assisted
Yes.
suicide. But again, it's like, how do we temper our political and emotional conversations about that, and how do we make it like scientific? Like how do we?
Yes.
So I don't technically know what each of these states calls it, but yes, there are many states where under certain circumstances, and if you meet certain criteria, you have the option to take medication that will end your life.
Yeah. So in many of these states, like it is super intense. It's not like, oh, I'm having a bad week. Like, let's go doc,
No.
right? You have to have a prognosis. The prognosis must be like you living less than 6 months. It has to be like legit. It has to
Some
be
of them
legit.
you have to be a resident of the state for a particular period of time. So it's not like, oh, hey, I found out that, I'm sick. I'm going to move to Oregon and next week I'm going to do this. Like, it really, they do build it that it's just like with, like, for example, we also take lung transplant patients. You have to go through screening for that. Like, are you emotionally and mentally stable enough for this? Are you, so, you have to think we are always kind of, assessing, how do I want to say this? I'm kind of losing my train of thought here because I'm taking too long to make the point. But basically, with end of life care, you have a whole different set of skills. Some of our patients, like I said, are end of life. Some of them are just there because they're receiving treatment and their symptoms are so intense. We can do things with medications that other services may not be comfortable with. Like, I've had patients that like are oncology patients and they have like intractable nausea, and we do a series of kind of off-brand or dosing that maybe other floors or nurses or doctors aren't comfortable with. So we have to learn like a completely different way of caring for these patients in an inpatient setting. And then you're running from one room where you have a patient that's full code and needs intensive cares and is very sick and wants to survive this. And then you're immediately walking into the next room and you have to change gears because people are mourning and it's a more tender care and you're not doing intensive rehab. And it's just, it's different to kind of flip back and forth. It takes some time, but this is where the community comes in. This is where if I see that we have a float nurse on the floor that looks like she's terrified because she has an end of life patient, I go, hey, I don't want to be pushy. You might be fine, but if you need some advice or coaching on how to medicate, because sometimes we get orders where we're giving Ativan every 15 minutes.
Yeah.
Most nurses on most floors are like, oh my God, I'm going to kill that
insane.
Person.
Exactly.
No, you're not.
You give when it
You're
needs to
giving
give.
them what they need.
Yeah. When the I forget what the score is. What is it? What's the scale that they use?
Which, I mean, there are lots of scales. Which one?
Because that's the one you pump.
We use the CWA scale.
Exactly, the CWA. For us, like in the beginning, I was the same way. I was like, it tells you to do the CWA as often. And like, if you are supposed to give it every 15 minutes, every 30 minutes, you like, am I really? But yes, you are really supposed to.
And I'll tell you this, the most, so I have 2 records. The most I've ever personally given a patient that was alive, well, at times alert and oriented. Once I gave a palliative patient with intense pain. I gave, and this is not an exaggeration, this is not a lie, I wrote this in my journal because I came home that day and I was like, holy fucking shit.
Right?
I gave a patient 256 milligrams of oxycodone in a 12-hour shift. And that patient was still having pain. They were not drug seeking. They had a legitimate diagnosis that was incredibly painful. And he was alert, oriented, conversing, and I was like, if I even took a 26 of what you're taking, I'd be on the floor.
Yeah, so I'll tell you. For those who not understanding, what I mean, like usually you give it 5, 10, 15
like every 4 to 8 hours.
Exactly.
Like,
so
Mhm.
200.
Mhm.
Homeboy was a tank. I
Yeah.
mean, he or
Yeah.
lady, she took it like a champ.
Yeah, but when you have nurses that aren't used to that, and you
Oh
come
yeah,
up
it
and
can
you've
be
got
very
orders
scary.
to give, 1 milligram of morphine every 30 minutes, as PRN, and
Exactly.
then you have these
And they're
nurses.
asking every second, every
Yeah,
minute.
yeah. I've kind of lost the initial question, but it's a very different world. So you have to kind of flip your head back and forth.
Before
It
we
can be
move
really
on from that,
difficult.
I wanted to know your personal beliefs on this, your personal
So
stand on
here's
this.
where I feel. A long time ago, I would have said, absolutely not. This is not how we operate as a civilized society. But then you know something? You
Yeah,
watch somebody writhe in pain after you've given them 256 milligrams of a chemical that's supposed to kill pain.
right.
And you see people go through these things for months and years. I had a patient years and years ago that I remember his face, I remember his name, I remember the conversations we had, and he had ALS, Lou Gehrig's disease. So essentially, you basically, from the feet up, he started losing functioning in his body. And when you get to a certain point, you lose the ability to breathe too. And that's why, as a pulmonary nurse, I take care of ALS patients. You see people with these illnesses and disorders, and it's literally just like watching a freight train come at you. And you see these people suffering and making sound. They're of sound mind, and they say to you, I've had people say, I don't want to do this anymore. And I say, I hear you. I get that. I personally no longer feel that it is immoral. I think that it is immoral to not have a death with dignity act, because these people already have to go through so much criteria. It's not like the death panels, like we're going to be killing grandmas left and right so we don't have to spend money. That's not it. That's not how the system is built. That's not, there's intensive screening. And then if anyone has ever seen the documentary, I can't remember, I think it's called like How to Die in Oregon. And it follows I'm getting chills, goosebumps even talking about it. There are these people that this woman says, she has a terminal illness, and she makes the choice with her family to get this bottle of medication that at any point she can drink and it will end her life. But she says, now that I have this bottle, now that I know I can control my own fate and stop myself from dying in excruciating pain and misery, now I feel like I don't need it. Now I can spend that time with my family. I can focus on being with those I love because the control has not been taken away from them. They don't have to worry about dying in misery. And to be very graphic, like, people are like shitting themselves. They can't get out of bed. They can't eat. They're in pain all the time. We can't give them enough medications to take away their symptoms. Until you witness that day in and day out, I don't think you have, I say you, but I just mean in general. I
Of
don't think
course.
people have a solid understanding of what it means to have a terminal illness. And I think that those more and more states nurses need to be going to bat for this. If you believe in this, you need to be pushing legislation. You need to be talking to, the governing organizations in your state, because while some people may be screaming at the computer, hell no. It's not until you hold someone's hand and they're begging you to end their life because they're in
Yeah.
so much pain. And that got real deep real quick, but it's true.
No, it's
And
very true.
and as a
And
nurse, you have to be able to go home and find that thing that lets you then shed it and let it go. Because if
right.
you hang on to that, you're not going to survive.
And I'm telling you, like for those people who don't know, and and if you're telling me that, like, let's take all of these assisted suicide laws, legislation off the books, like let's get rid of all of it, you have to understand that when you are a nurse and you see the total opposite of that, instead of helping someone die, have a peaceful, lovely, wonderful death the way they choose,
Mhm.
the opposite of that is keeping everyone full code. And when you see a 90-year-old grandmother who and they code and you have to jump on top of their chest.
As a nurse, you're like, I'm going to crush you. I'm going to crush you
Yes,
beyond belief for no reason.
exactly.
This
Just
isn't
so
going to
we
help.
could break a rib, you could get pneumonia, you could go back into the ICU and
Get
die
septic,
vented.
right? Hmm.
It's like
Yeah.
seeing the opposite of like allowing the patient to go the way they want and just making sure we do everything we can 24/7 for every single patient. Like it really ends up being
It's
a
intense.
no-brainer, right? It ends
It's
up being a
intense, but
no-brainer.
but some people take a long time to get there because
Of
everybody has their
course.
own experience and their own morality and their own, religious or spiritual beliefs. I
So
Yeah.
So can we talk a little bit about, I know I'm talking about real downy things, but we're going to change in just a hot minute. But
Sure,
how,
sure.
how do you deal with when you're taking care of a patient and it's obviously their time to go, but the family is asking and the patient's nonverbal, the patient's dementia, they're confused, whatever the situation.
Mm-hmm.
How do you guys deal with the situation? And have you ever had to take anything to the ethics board where the family is like, we want everything. We want every tube, every vent, every measure, everything. Is
Yeah.
that something that you've dealt with? And how do you go through dealing with
So that does happen. And I've seen it end a lot of different ways. I've seen family members eventually come around and say, like, I understand. I see that they're suffering. I see that this, but sometimes it takes people a long time to get through to that. I know that in my hospital, we have an ethics committee,
Yes.
and they are very active and involved, as well as, like, I think our physicians, especially our palliative care team, they consult with teams throughout the hospital. So we're trying to make it so that palliative care is available to everyone. But you see a lot of patients by the time they come to us, if they're full code, and there are times when the nurses are like, oh my God, this is going to go to shit. I just know it is. And I hope it's not on my watch. And you feel like you're passing a hot potato. And, at times you try to do education with the family and say, like, in very tactful ways, we can't fix this. I can only manage this for a time. Like, you want to have those conversations wherein you say, I'm about to hurt her in doing this wound debridement, this
Yes.
therapy, this physical
Yes.
therapy. This is going to hurt. And they can't decide for themselves right now. So I'm counting on you to be able to recognize together if the hurting is going too far. And sometimes it's hard. Sometimes people don't listen. Sometimes you can bring in the ethics committee, you can bring in other nurses, the physician, and sometimes people are just, they're not in a place where they can hear it. They're not ready, they're not willing. Sometimes you're treating your patient's family members as well as the patient, because like, I've had patients that have been actively dying for days. They've been nonverbal, and they like move their hand a little bit, and the family member is like, oh, is she going to recover? Should we take her off? Should we take her off end of life care? Like, she squeezed my hand. And it's like, well, then to kindly and not cruelly explain, well, that's a reflex, and putting your hand in someone's hand is not meaningful motion. Now, if you say, hey, let go, and they let go, that
That's
indicates
different.
choice and consciousness and the ability to act on it. So it's really hard when you have people that are suddenly like, oh, she said a word, she opened her eyes, and in your head as a nurse, you're like, well, this might be the final rally. Like, we can't change the underlying pathology that is, it's a tough situation. I don't know that I'm giving a good answer to this, but you need
No,
to,
it's the only answer you can give.
yeah,
It's
it
rough,
really is.
right?
And you need to, and that's when you especially rely on the coworkers that you trust, that have done this work. I look to my senior nurses a lot.
Yes.
Hey, what would you do in this case? I've even had new nurses say to me, this family member is intense. I don't know how to answer their questions. I feel like they're running me through the mill. And I'll go in and I'll say, hey, I heard you had some questions. I've worked here a long time. I really just wanted to make sure, your nurse, I never throw the nurse under the bus. I never say, oh, well, your nurse is new, so she doesn't know, so I'm talking.
Yeah.
Because then they're going to be like, well, you just be my nurse. Like, then forget that person. But really what you need to say is, this person, your nurse recognized that maybe you guys aren't communicating well on this, and she or he wanted to make sure that you had this information. Or, like, if I have a patient that's like, a nurse that says, like, I need you to come in and help me go through this, I say things like, as I'm just going to pick a name, as Jenny told you, these are some symptoms that you can expect to see. As Jenny was trying to demonstrate, or like what Jenny's been doing supports what I see, which is this. So I try to not only give my patients and their family members confidence in their nurses, but if that nurse is like, holy shit, I need help, I try to step in, because I do have the soothing voice, the therapeutic communication. That's something that I happen to be good at. I've never been involved in a code, though. So if you need somebody to like jump on the chest, I might be kind of like, for a second, I would react, but that initial reaction might. Whereas with end of life care, if somebody's like, "Hey, I need help talking to this family member," I'm like, "I got you, boo. I'm in. I'm down. I can
Let's
do
do
that."
it. Let's do it.
But I think that kind of philosophy, as well as the whole philosophy of this podcast, is that every single nurse, whether you've been on the job a day or 100 years, you have something valuable to bring, because maybe you read an article that another nurse didn't read, or maybe you had a patient that another nurse has never had before. You can be a nurse for 40 years and you can get a case that you've never seen before.
Exactly.
All of this is possible. So I think
Which is kind of the exciting part about nursing. I mean, it is super
it is.
exciting.
It is.
Nursing can be
Everybody
super
has something,
exciting.
and everybody has something to bring to the table. You are bringing things to the table with your shows, talking about these hard topics, really polarizing topics. I thought you were going to ask me about the nurses that were charged with manslaughter during the
Oh yeah,
hurricane.
you better
Because
believe it.
that's
Are
something
you
that
in
I got
you're in Florida?
no, I'm actually I'm in the center of the country in Iowa. We are a landlocked state. But I have a friend that's in Florida right now as we speak.
Yes.
So I pay attention to these things.
So
But
we'll get there, but I do
yeah.
want to switch. I want
But
to.
I'm
I want to
saying,
get
like,
on.
you're providing a service too.
Oh,
So
thank you,
yeah.
Adrian. I appreciate that. It's good to
Yeah.
hear.